Malignant Lesions of Breast by Dr. Dilip Giri. With this, we start today's session. Dr. Varsha, madam, would start sharing your screen.
Yeah. Hopefully you all can see my screen. Yeah.
Yes, ma'am. Yes, ma'am, it does.
Okay. So today's topic is the benign breast lesions. So this is the outline how I'm going to do. First, I'm just going to talk about benign epithelial lesions of the breast, and then move on to how to approach breast needle core biopsies. Just to briefly reiterate the anatomy and histology which you all learned day before yesterday. So this is the collecting duct here, then lactiferous sinus, segmental duct, subsegmental ducts, and then we have terminal ductulo-lobular units, or also called TDLUs. And most of the breast epithelial proliferations arise from TDLUs. So here is the normal histology of the TDLU. So we have terminal ductule, and then we have the lobules here. And both the ducts as well as the lobules, they are lined by inner epithelial layer, and then there is outer myoepithelial layer. Usually the cells of the myoepithelial cells are kind of vacuolated. And just outside the myoepithelial layer, there is a thin basement membrane, which is very difficult to see on H&E, but can be highlighted by special stains for the basement membrane. And this is kind of highlighted by the CK5-6 stain, which will stain the inner epithelial cells patchily, as well as it will stain the myoepithelial layer as well. So what exactly is hyperplasia? So with any stimulus, when you get uncontrolled proliferation, it leads to hyperplasia. But when you remove the stimulus, it then reverts back to normal proliferation. In contrast with in neoplasia, where you get uncontrolled proliferation with stimulus, but when you remove the stimulus, the proliferation continues. So these neoplasias could be either benign or malignant, and I'm only going to talk about the benign ones today. So this is the latest WHO classification of the breast tumors, benign breast tumors. So we get benign proliferations we have, which are hyperplasias. We have adenosis and its variants. And then we have, we have adenomas and biphasic tumors. So first I'll talk about the benign lobular proliferation. So this is just a schematic diagram of the lobular proliferation. So this is simple adenosis, that is sclerosing adenosis. You can get a cystic change within adenosis, and you can get apocrine metaplasia within adenosis. So basically in simple adenosis, you get expansion of the lobules and increased number of lobules. So under the microscope, so that's normal, and that's the expanded lobule with increasing number of the acini or the lobules. So this is simple adenosis. And again, simple adenosis will be lined by inner duct epithelial layer and outer myoepithelial layer. So again, it's the same immunoprofile as the normal. In contrast, what is sclerosing adenosis? It is a variant of simple adenosis. So what happens that there is a fibrotic stroma between the acini. That stroma starts compressing the glands. So these glands become very atrophic. So that's why you get sometimes you get linear arrangement of the cells. But the typical nature of sclerosing adenosis is that it is a lobulocentric proliferation. So under low power, you will still appreciate the normal lobular architecture of the sclerosing adenosis. So that's the high power. Again, you can appreciate that there is the normal lobular architecture is well preserved. And that is another example. Again, you can see there is a kind of normal kind of lobular architecture with streaming of cells here. Same again here, and you can appreciate how the glandular structures have got compressed by the fibrotic stroma, and then cells are literally kind of arranged in a linear pattern, mimicking invasive lobular carcinoma. But because sclerosing adenosis is just a variant of adenosis, the outer myoepithelial layer is still preserved. So if you do myoepithelial markers, for example, P63, it will highlight those myoepithelial cells. So there are some glandular epithelial cells here which are not stained by the P63 stain, but the myoepithelial cells are stained by them. So that is the difference between if you are really stuck, is it invasive lobular carcinoma or is it sclerosing adenosis, then you can confirm it by P63, which will highlight the myoepithelial cells. They would be absent in invasive lobular carcinoma. Apocrine adenosis is another variant of adenosis where the ductal epithelium, the inner epithelial layer undergoes apocrine metaplasia, and again the myoepithelial layer is well preserved. And within the apocrine lesions, we have a spectrum. So we have simple apocrine adenosis, atypical apocrine adenosis, DCIS, and invasive carcinoma. Between simple adenosis and atypical adenosis, the nuclei become atypical. They are almost 3 times the size of the lymphocyte. Sometimes it is pretty difficult to differentiate atypical adenosis from apocrine DCIS. But in apocrine DCIS, we will get marked expansion of the lobules, as well as there is necrosis, and you will find some mitotic figures as well. So you are basically looking for necrosis and mitotic figures to make a diagnosis of apocrine DCIS. So now moving on to intraduct proliferation as opposed to lobular proliferations, you can get usual ductal hyperplasia, atypical ductal hyperplasia, and ductal carcinoma in situ, which I won't be covering today. So this is just the schematic presentation, benign, atypical, and malignant, which could be in situ or invasive. So we have a normal here, and usual duct hyperplasia. So what's the difference here? What happens in usual duct hyperplasia is that both this inner epithelial layer as well as myoepithelial layer both proliferate. But the proportion of epithelial cells versus myoepithelial cells may vary. So you may have more epithelial cells or you may have more myoepithelial cells. While in DCIS, only the inner epithelial layer proliferates, and it is the neoplastic proliferation is opposed to UDH. But the outer myoepithelial layer does not proliferate. So what happens that when the duct gets expanded, these myoepithelial cells may become very atrophic, particularly in high-grade DCIS. Sometimes you may just see interrupted layer of myoepithelial layer. So that is the difference between UDH and low-grade DCIs. And then obviously invasive, the cells break through the basement membrane and become invasive carcinoma. Like in other organs, if you can see the basement membrane, then you can say it is invasive carcinoma, it is broken through the basement membrane. But because in the breast it's very difficult to see the basement membrane, we use absence of myoepithelial layer as a surrogate marker for invasive cancer. So in DCIs, in situ carcinomas, you do have this peripheral myoepithelial layer, while in invasive carcinomas, there is absence of peripheral myoepithelial layer, with a notable exception, which is microglandular adenosis. So just to kind of highlight this, CK5-6 in normal, you have presence of outer myoepithelial layer. In usual ductal hyperplasia, there is inner epithelial layer proliferation and the preservation of the myoepithelial layer. In DCIS, the inner epithelial proliferation is CK5-6 negative, it is neoplastic, while the outer myoepithelial layer stays with CK5-6 and is preserved. And here in invasive cancer, we are not seeing any myoepithelial cells. So this is the spectrum of ductal proliferation. So we have benign here and malignant here. I'll come to this B category a little later, which we use in the UK. And we have another category, which is called ADH, which is atypical ductal hyperplasia. So what exactly is atypical ductal hyperplasia? It is a neoplastic proliferation. The cells are identical to low-grade DCIs. Morphologically or genetically or immunohistochemically, there is absolutely no difference between the cells of low-grade DCIs and ADH. And the ADH term is reserved for low-grade lesions. Once it is high-grade, you can't call it ADH. So it has to be low-grade neoplastic proliferation. So we have certain criteria of when do you call it ADH. Either the duct is only partially involved by this neoplastic epithelial proliferation. Like here we have some usual hyperplasia, but here we have some neoplastic clonal proliferation of low-grade epithelial cells. Or, so this is the qualitative criteria or the architectural criteria, or you can have quantitative criteria when it measures less than 2 millimeter, or involvement of less than 2 ducts are completely involved. We call it ADH. So basically ADH is nothing but underdeveloped low-grade DCIs. So there is morphological overlap, immunohistochemical overlap, as well as similar genetic profile. So now coming to usual duct hyperplasia, which I told you about, that there is proliferation of both epithelial and myoepithelial cells. And here we have a cribriform architecture. So your differential diagnosis is not in typical cases, but sometimes it can be confused with low-grade DCIs. So how do you differentiate usual duct hyperplasia from low-grade DCIs? So they both have cribriform architecture, but if you look at the spaces, there are irregular spaces here, while here they are punched out spaces. So that is the difference in the architecture. If you look at the cells now, because there is proliferation of both epithelial as well as myoepithelial cells, you will get a different population, dual population of cells here, while here you will get a monomorphic population of cells because it is only the inner layer which is proliferating. The cells will be streaming. Here there will be nuclear overlapping, while here they are kind of evenly spaced out nuclei. There is no nuclear overlapping here. And then if you look at the bridges or the bars, they are kind of very rigid. They are not tapering bars, while here they will be tapering bars. You can sometimes get a little bit of necrosis in usual duct hyperplasia. That does not exclude the diagnosis of usual ductal hyperplasia. And also you can get occasional mitotic figures. So both these features, if present in small amount, do not rule out the diagnosis of usual ductal hyperplasia. You have to rely on the other morphological criteria. And then if you are really stuck and you can't differentiate, is it usual ductal hyperplasia or is it low-grade DCIs, then you do CK5-16, which is mainly cytoplasmic. It is a high molecular cytokeratin, so you can either use CK5-6 or you can use CK14. It's a cytoplasmic, mainly cytoplasmic staining, basic membranous staining. It does not stain nucleus. It stains benign epithelial cells and myoepithelial cells. Remember that it also stains myoepithelial cells. And this is typically negative in malignant ductal epithelium. Okay, typically, I'll come back to it a little later. Why I said typically, not always. So what do you see with CK5-6? Because it is typically positive in benign epithelium, negative in malignant epithelium. So we have CK5-6 positivity here. It may not be uniformly positive. You may get just patchy positivity. But here in DCIs, the CK5-6 is negative. Again, it may not be always completely negative, particularly when it is papillary DCIs. You may get scattered myoepithelial cells here and there. It doesn't rule out the diagnosis of DCIs. And again, as you can see, there is a preserved peripheral myoepithelial layer. So that is usual duct hyperplasia where I showed you a cribriform pattern. Now this is a different pattern. It's called micropapillary hyperplasia, or it's also called gynecomastoid hyperplasia. Because typically this type of hyperplasia you see in gynecomastia. So how do you then differentiate? Obviously, your differential diagnosis is micropapillary DCIS, right? So how do you differentiate the two? Now, on morphology. In micropapillary hyperplasia, you have broad-based papillae. First of all, there are no true papillae. There is no fibrovascular pore either in this or in here. But the base is broad, and the papillae over here, they become kind of as if somebody has pinched the top of the papilla. So they become narrow. So the broad base and narrow papillae is micropapillary hyperplasia, while just the opposite in micropapillary low-grade DCIs or high-grade DCIs, you get broad bulbous papillae. So the base is narrow, and the papillae at the top are bulbous. Okay, that's the main difference morphologically. And then obviously, if you look at the nuclei, they will be more evenly spaced out, just like low-grade DCIs. There may be prominent nucleolus, while here there will be more overlapping. And if you see the bars or the bridges, they will be tapering type, while rather here they would be rigid bars. So that's the difference between micropapillary hyperplasia and micropapillary low-grade DCIs. And because it is hyperplasia, if you do high molecular weight cytokeratin, you will get the staining for patchy staining for cytokeratin 5-6, while in DCIs, it will be negative. Now, if you use any immunostains, you have to know what it stains normally, what are the pitfalls, and what type of staining to expect. So CK5 what are the caveats? As I said earlier, that it is typically negative in malignant ductal epithelium, but it can be negative in some of the benign epithelia. So when you get apocrine metaplasia, and you are trying to decide whether it is DCIS or it is just hyperplasia, CK5 is not going to help, because CK5 is negative in benign apocrine epithelium. Also, when you get columnar cell change in any lesions, even if it is benign, CK5 will be negative. So here is a benign papilloma, and you can see at the surface, it is kind of a columnar cell change. And if I do CK5 stain, you can see the columnar epithelium is completely negative. Myoepithelial layer is present, but the columnar epithelium is completely negative. So when it is columnar epithelium, particularly single layered, it will be CK5 negative, even if it is benign. So you have to know this when you are trying to analyze your papillary lesions. And this is papillary apocrine hyperplasia. Again, if you do CK5, it may be negative, but don't call this a papilloma. This is not a papilloma. This is not an interduct papilloma. This is or a micropapilloma. This is just the benign papillary apocrine hyperplasia. Like in the UK, we excise all the papillomas, so we shouldn't be calling this papilloma. This does not need any excision, completely benign. Okay, so when is CK5 positive in malignant epithelium? When you get basal-like malignancy, whether it is high-grade basal-like DCIS or basal-like invasive carcinoma, your CK5 is going to be negative, but it will be high-grade. So your differential diagnosis is not going to be low-grade DCIS versus usual hyperplasia. It will be usual hyperplasia versus high-grade DCIS, which usually is not a problem to differentiate. So just remember that CK5 will be positive in basal-like malignancy. Okay, so that's the hyperplasias and adenosis. Move on to fibroadenoma. It's a biphasic tumor. So we have epithelial and mesenchymal component. Two patterns typical, pericanalicular, intracanalicular, but which could be mixed. You can get mixed patterns in both in fibroadenoma. So what could be the differential diagnosis of fibroadenoma? Hamartoma, but it is a benign lesion. So if you are not able to differentiate whether it is hamartoma, fibroadenoma, it's not a problem as long as you are 100% sure that it is benign. So don't try too hard to differentiate hamartoma from a fibroadenoma. Cellular fibroadenoma, your differential diagnosis is going to be phyllodes tumor at the benign end of the tumor. So it is the benign phyllodes tumor. And here it is important to differentiate the two because benign phyllodes tumor needs to be completely excised if you have diagnosed it on needle biopsy because it has a risk of local recurrence. It needs wider margin, but not really very wide margin. Even a little bit of adjacent breast tissue should be enough. So that's why you need to differentiate cellular fibroadenoma and phyllodes tumor. So how do you differentiate the two? Obviously, the phyllodes tumor also has cellular stroma. You typically get periductal cuffing, so the condensation of the stroma around the ductal epithelium. You get these clefts or the cyst-like spaces within which you get these leaf-like projections. Now, if it is a benign, it's a malignant phyllodes is never going to be in the differential diagnosis for fibroadenoma. It's the benign one. So in benign one, you may or may not get mitotic figures. You may have in phyllodes tumors, you may have infiltrative margins, but again, in benign phyllodes tumor, you may have very little infiltrative margin. So that also doesn't help much. So here is a fibroadenoma, and this is a phyllodes tumor. So in a sense, this is not particularly a cellular fibroadenoma, but if it was a cellular fibroadenoma, the cellularity is usually uniform. While in phyllodes tumor, you get patchy areas of cellularity. So that is one difference. Second difference is these projections they are like, in a fibroadenoma, they are like jigsaw-like pattern you get. They fit into each other. While in phyllodes tumor, they don't really fit into each other. So that is kind of one softer point sometimes can help you to decide whether it is a fibroadenoma or phyllodes tumor. So that's what I would say here. There is periductal condensation of the stroma. In fibroadenoma, you don't get that. You get a cellular stroma away from it as well. Very few mitotic figures if it is a benign phyllodes tumor. But there are caveats as well, because fibroadenoma obviously can show cellular stroma. It can have focal leaf-like projections. But as I told you earlier, this projection fit into the cystic spaces, just like a jigsaw puzzle. While in phyllodes tumors, they don't. You can get occasional mitosis up to 2 per 10 hypophils in a fibroadenoma. In contrast, phyllodes tumor, benign phyllodes tumor, can show fibroadenoma-like areas within it. So on a needle core biopsy, it can be missed because you can have a sampling error. It may look like fibroadenoma, but it was actually phyllodes tumor. And that's why the triple approach comes into the, I'll show you how you take these cases forward then. And the phyllodes tumor can be circumscribed with very little or non-inflammatory margins. And that is why we have a significant inter-observer variation to differentiate cellular fibroadenoma from benign phyllodes tumor. Okay, so far we just talked about adenosis, hyperplasias, and fibroadenomas. But what happens when you get epithelial proliferations within a pre-existing benign condition? And then it gets even more difficult. And because it can mimic in situ cancer or it can mimic even invasive cancer. So let's look at some of the examples here. So within a fibroadenoma, you can get hyperplasia, usual hyperplasia. You can get sclerosing adenosis. So we label this type of fibroadenomas as complex hyperplasia, complex fibroadenoma. And that can mimic in situ malignancy if it is usual hyperplasia. And if there is a lot of sclerosing adenosis, it can mimic invasive malignancy. Similarly, in sclerosing adenosis, you can get other proliferation. You can get hyperplasia, you can get LCIS, lobular carcinoma in situ, or you can get ductal carcinoma in situ within sclerosing adenosis. And because sclerosing adenosis has this pseudo-infiltrative architecture, you can imagine that if it is involved by LCIS or DCIS, it will look like invasive carcinoma. But as I said earlier, in sclerosing adenosis, the myoepithelial layer is preserved. So the if you do myoepithelial markers, you will get positivity at the periphery. So this is the example of in situ cancers within sclerosing adenosis. And this looks like kind of invasive duct carcinoma. And here it is LCIS, which is involving sclerosing adenosis. It can mimic invasive lobular carcinoma. But if you do P63 stain or any other myoepithelial stain, but I like P63 stain mainly because it is a nuclear stain. It is much, much cleaner. You can use smooth muscle myosin heavy, you can use calpone. I don't like S100 because it's not very sensitive. So I prefer P63, but you can use other myoepithelial markers. So that's just to kind of summarize normal epithelium, usual ductal hyperplasia. The differential diagnosis would be low-grade DCIs sometimes. And up to here, you have preservation of the myoepithelial layer up to the DCIs. And then once the myoepithelial layer is lost, which is a surrogate marker for invasive cancer. So that would be your invasive cancer here. So I think I'm going to stop here and just one quiz question for the audience.
So I'll read
Just
out the
checking whether you are awake.
Yeah, I'll read out the question for the students. Which of these processes does not regress after removal of stimulus? Option A, hyperplasia, option B, metaplasia, and option C, neoplasia. So most of the students think it is option C, neoplasia.
That's right. Correct. Yeah. So neoplastic process here does not regress after removal of the stimulus usually. Yeah. Okay, so I think I stop here if there are any questions.
Dr. Shalaka, can you see any question from the
No.
students? Okay.
There are no
So-
questions in the chat box.
Okay, so maybe we can take it to the Jilu sir and Mandar sir for their brief comments. So,
Dr. Zilu, sir, do you have any comments?
Thank you. The talk was excellent. I like to thank Dr. Varsha for excellent description of the benign breast disease, and she very briefly described about the hyperplasia and adenosis, the differences between the hyperplasia and adenosis, and use of immunohistochemistry in the benign breast lesions like P63 and CK56, which are very essential. In many cases, we feel difficulty in the diagnosis of the benign breast disease, which may mimic the malignant lesions. So it is very essential to learn about the immunohistochemistry. I appreciate that Dr. Varsha has very specifically mentioned about these. And on the other hand, she also described about the papilloma versus micropapillary hyperplasia, which is very essential to learn, especially for the beginners. And the complex lesions are also described very precisely. And the total scenario of the benign breast lesions are now in our brain, I think. The non-inflammatory benign breast disease is discussed in this part. And what are the difficulties in differentiating from the malignant lesions are also described well. I think it's enough for me. Thank you very much.
Madam, there is one question in the chat box. Do infiltrating duct carcinomas develop from previous DCIs?
Yeah. It is DCIs, we call it a non-obligate precursor. So what happens is that not all DCIs develop into invasive cancer. So the invasive cancer develops from DCIs, but sometimes you may not see the adjacent DCIs because it has been taken over by the invasive cancer. But DCIs is a precursor of invasive duct cancer, yes.
Okay.
But you
Can I
have to remember that not all DCIs progress to invasive cancer.
Hello, can I say something?
yeah, Mandar sir.
Yeah,
please.
hi. Sorry, I'm driving on my way home, but that was a very nice lecture, Dr. Varsha. Thank you very much, and especially, I think all other are pathologists, so most of them knew most of it, and for me, it was really great to know a lot of things, maybe basic things for all of you, but for me, I think they were really eye openers. The three things I'm just saying this from a clinician's point of view, me being a breast surgeon now for a few years, is that the three things that I always sort of need clarity on when I'm treating patients is one, fibroadenoma versus benign phylloides, and you really very nicely put the whole thing out there, and that is very important from my point of view as to whom to treat with how much of a margin and what to do.
Yeah.
That's one. The second thing is ADH versus DCIs again tells me, it's very important for me to know when to operate and when probably to observe or what and how to counsel a patient. The third other thing I actually always end up having a few issues on is when we have a patient who comes to us with a solid cystic lesion, a lady maybe in her 50s, and we do a sort of an excision, a wide excision if indicated at some point in time, say in a 60-year-old lady, and then we end up having a few questions about whether this is going to be a benign lesion, a malignant lesion, what exactly. I mean, I went, maybe as part of your question answers, if you could also address this, that would help maybe the pathology, but definitely would help me.
Yeah, I'm actually going to come to now the second part of the talk, which is the approach to the needle core biopsies. So once we have taken down these questions,
solid cystic lesions?
Sorry?
Where you'll be addressing solid cystic lesions as well?
I mean, I'm going to address the needle core biopsy approach.
All right,
and
okay.
then the ADH and DCIs also I'll talk about. So if I can now go on to the second part of the talk, is that okay?
Yes,
There are a couple of questions. Would you like to take them now?
Should we go on to the second part first and then?
Okay, sure, madam. Yeah.
There was actually one more question for you guys. Do you want to just take this quiz as well?
Should I read out?
Yeah.
Epithelial cells are typically CK56 positive in which proliferation? A. Hyperplasia of usual type. B. Ductal carcinoma in C2. C. Invasive ductal carcinoma. Okay, so there are mostly A's, hyperplasia of usual type.
Yeah. Yeah, that is typically positive in CK56 with one caveat, that basal-like malignancy. Good. So we can move on to the next one now.
Okay, madam. Yeah.
Okay, so approach to breast needle core biopsies. As you all know that now needle core biopsies are becoming more popular, mainly because you really don't want to excise a benign breast lump, for example, fibroadenoma, just for the sake of diagnosis, to get a diagnosis, when you can easily get a diagnosis by needle core biopsy. So you want to avoid benign excisions. And even for malignant excision is useful because the surgeon can plan the treatment before he or she does the therapeutic surgery. And if the patient is eligible for neoadjuvant chemotherapy, we can give all the useful information to the oncologist as well. So they are becoming very popular. We hardly do any FNAs here. Most of them are needle core biopsies, which are usually performed by the radiologist under radiological guidance, either ultrasound or it can be stereotactic biopsy. So let's look at it. How do we approach it? So what are the types of breast lesions? There are symptomatic lesions, which are usually palpable mass lesions. So if it is cancer, most likely it's going to be invasive cancer. The CIS will be only 1 to 5%. While radiological lesions are the ones which are mammographically detected, and they're in the UK, because we have the breast screening program, most of them are picked up on mammography or either MRI or mammography. So what are the types of mammographic abnormality? You can have a mass lesion, as you can see here, which can be either rounded or stellate mass lesion. And even the mass lesion which is rounded, it could be solid or cystic. It could be asymmetric density or architectural distortion. It could be radial lesion, or it could be microcalcifications. And this, you all are probably familiar with this by-rates category. So whenever the radiologist looks at the mammogram, they try to classify the abnormality into these categories. R1 is that there is no abnormality found. So basically it's a normal mammogram. R2, they feel it is benign. And if it is benign, probably they won't do a biopsy. R3 is uncertain, probably benign. R4 is suspicious, and R5 cancer. So R3 onwards, they will probably do a biopsy to see what the lesion is. So when you are told that it is a rounded mass, what all you will think of before even you look at the biopsy? If it's a solid mass, it is likely to be a fibroadenoma, or if it is cystic, just a benign cyst, or it could be an intraduct papilloma. So these are the benign lesions which could present as rounded mass lesions. Or it could be an invasive cancer. So high-grade invasive cancer can be very well circumscribed, or a mucinous carcinoma can be very well circumscribed, and both will be solid. High-grade, particularly metaplastic cancer, if it has necrosis in the center, it will look like a cystic mass. It will look like a cystic rounded mass. So sometimes radiologists do get surprises that when they say fibroadenoma, and we would say it is a grade 3 invasive duct carcinoma. Stellate mass could be a tubular carcinoma or any other invasive duct carcinoma. Asymmetric density or architectural distortion, just fibrosis can cause asymmetric density. Sclerosing adenosis will cause asymmetric density, and then invasive lobular or ductal carcinoma. Radial lesion, the differential diagnosis would be radial scar or a tubular carcinoma. Microcalcification, I suppose you probably won't see a lot of core biopsies for microcalcifications, but here in the UK, we see a lot of them. And anything can present with microcalcifications, right from benign to atypical to inside to invasive cancer. So these are all the benign microcalcifications, fibroadenoma, cyst, sclerosing adenosis, etc. These are your flat epithelial atypia, ADH, DCIS, LCIS with comedonecrosis can present as microcalcifications. And finally, obviously, invasive duct carcinomas can have calcifications within it. So how do you interpret a breast core biopsy? What are the really problems with benign breast lesions in the core biopsy? The problems are either you are not aware of an entity, or you are aware of an entity, but you are not familiar with the entity. Sometimes there are poorly defined criteria for benign versus low-grade cancer. Misuse of immunohistochemistry. Now, I emphasize this again and again because you really need to know why are you using immunohistochemistry? So you have to first form a differential diagnosis. What is your differential diagnosis? And then decide on appropriate immunostains. Don't blindly request a whole panel of immunostains, and then you will get totally confused. Know about what is supposed to stain. Decide in the beginning only, okay, I'm requesting these immunostains. If it is positive, how is it going to help me? If it is negative, how it is going to help me? Okay, and then you have to know the pitfalls and the limitations of immunohistochemistry. And needle core biopsy, obviously the major problem is the sampling bias. You have limited material. You may not see the architecture appropriately. So these are the problems in the needle core biopsies. And the main other thing is the lack of histology radiology correlation. And this is the key for interpretation of breast core biopsies. So most important is histology radiology correlation. So how do you do this correlation? Make sure you get the clinical information. They have to tell you what is the nature of the target lesion. Is it done for mass lesion? Is it done for architectural distortion? And if it is done for mass lesion, is it a rounded mass or is it a stellate mass? Is it a solid mass or cystic mass? Our category also is very, very important. They have to tell us how suspicious they are, size of the lesion and type of biopsy. So when you get your H&E slide of the core biopsy, how will you approach it? Obviously, carefully look at the clinical information, see what is it done for. And then first screen under low power. Never go and jump onto high power right at the beginning. Decide whether the targeted lesion is present in the biopsy or not. So how do you decide that, whether I have got a lesion in the biopsy or not? Look for the interface. So what do I mean by that? So here is the, this was a mass lesion. Yeah, here is the mass lesion. This is not obviously a benign lesion. It's drawn as a cancer. But whenever a here, as I said, that most of the biopsies are done by radiologists. When they do a biopsy, they always try to take the adjacent breast tissue. So you will get an interface of the lesion with the adjacent breast tissue. And that is very helpful. So here is a needle core biopsy. I mean, this is very obviously a fibroadenoma, but here you can see the interface. This is normal fatty breast tissue, and this is the lesion. So you have a well-demarcated mass lesion. So once you have seen that under low power, yes, I have got a well-demarcated mass lesion. I'm happy that the targeted lesion is present in the biopsy, and then try to decide, is it benign or malignant? And if it's benign, then you obviously look, is anything else going on in the lesion? And also outside the lesion. Don't ignore the adjacent breast tissue. Sometimes there may be more adverse lesion in the adjacent breast tissue. So here is a thing that needle core biopsy done for a mass lesion. I mean, it looks like normal breast tissue, maybe a little bit of fibrocystic change. But how do I know that the targeted lesion has been biopsied? So I look for the interface, and you can see there is a nice interface here. That's the normal breast tissue there, fibrous breast tissue, and that's the mass lesion. And once I have decided that, yes, I'm seeing the targeted lesion and it is all benign, there is nothing else going on there. After, it doesn't matter what you want to call it. Do you want to call it fibroadenoma or fibroadenoma variant or hematoma? It doesn't matter. The terminology there, once you've decided that it's benign, nothing else is going on, it doesn't need to be excised. It doesn't matter what you call it. And so this was a hematoma. Now, this was another one biopsy. The previous biopsy was performed, but it was B1. I will come back to it. What is B1? B1 means that the targeted lesion was not present in the biopsy. So, one second, I have to. Yeah. So here it looks like a normal breast tissue. Yeah. But in the biopsy, we got only this. There was no interface in the biopsy. So obviously it was called inadequate biopsy because we are not seeing the targeted lesion. Stop now. Okay. So because we call it B1 or the inadequate biopsy, no target lesion present, they excise the lesion. And you can see the lesion is very well circumscribed with a nice interface between the lesion and the surrounding fatty tissue. So this was a very typical hematoma. So we were happy that we have got a benign lesion here. And then once you have looked at it, then you have made up your mind, okay, it looks like fibroadenoma, I'm happy. But then see whether the histological diagnosis correlates with your radiological diagnosis. If the radiology is, say, R4 or I5, and you are calling it benign, then there is a discrepancy here. So it's a discordant diagnosis. So before you give the diagnosis, you have to think twice, what has gone wrong here? And I will discuss that a little later now. And this is what I was talking about, the diagnostic B categories. We find it quite useful here because it's useful for the clinical management as well as for audit purpose. So what is B1? Means that the biopsy has been performed, but I have not found the lesion in the biopsy. So it is no abnormality found. I've just got benign breast tissue. So don't report it as just benign breast tissue B2. No, it would be benign breast tissue, but B1, because I have not found the targeted lesion. So what they will do is they will repeat the biopsy. Okay? B2 we give when they say it was R2 or R3 mass. Surgeon is also happy that it looks like fibroadenoma. I have got a fibroadenoma. All three of us are happy. Radiologist is happy. Surgeon is happy. Pathologist is happy. It's B2, discharge. No need to do anything more. B3 is that atypical category where it's ADH or LCIS, where it requires excision, but it is not enough for malignancy. That's B3. Either you excise it. Here we perform vacuum-assisted biopsy to get more tissue. So we hardly excise the lesion anymore now. Most of them, they turn out to be benign. So we do vacuum-assisted biopsy. B4 is suspicious, means I'm very suspicious that it is invasive carcinoma or it is DCIS, but I want little more tissue to make sure that it is to give a definite diagnosis. So it's suspicious. When we say B4, they will repeat the biopsy. And B5 is cancer. That means patient needs therapeutic surgery. So patient needs treatment. It could be either in situ or it could be invasive. Okay. So when we write the report, I would say, suppose it's done for mass lesion. I've seen fibroadenoma. So I will say in my cross-section, fibroadenoma, B2. Usually the surgeons only look at this B category. They never bother to read the reports. So once they see B2, they know, okay, I can discharge the patient. And when they say B4, okay, we have to repeat the biopsy. So it's quite helpful for them. So it is the triple assessment which is important, correlate with clinical findings, correlate with radiologic findings, and correlate with pathologic findings. So when it is R5, so BI-RAD category 5, pathology category 5, either A or B, it's a concordant biopsy, go ahead and treat. When it is R2 or R3, we got a benign diagnosis, which is B2. And as a pathologist, we are sure that the lesion is present in the biopsy. It's a concordant biopsy diagnosis, and so discharge the patient. R2 or R3, B3, so it is atypical. You either excise or do vacuum-assisted biopsy. Okay, so what happens when you get a discordant biopsy result? So we have R5. It was radiologically very suspicious, but I have got a B2 diagnosis. So it's a discordant diagnosis, right? Is there any explanation? So for example, fibromatosis, yeah? Fibromatosis can look like R5 lesion because it's an infiltrative type of lesion, but it is benign. It does require excision, but it is benign. So ideally it would be B3 rather than B2, but it is benign. So if you have any explanation, it is fine. Then we can explain to the radiologist or the surgeon that it looked like R5 mainly because it was infiltrative lesion. But if you don't have any explanation and the radiologist is completely sure that it is an R5 lesion, it's quite likely that the biopsy missed the lesion. So the repeat biopsy would be required. So here is a case which I had a few years ago when I was in America. And this is the case where she was a 30-year-old. She presented with a mass lesion in the right breast. A true cut biopsy it was not a radiologically guided biopsy. It was a true cut biopsy performed by a surgeon. The reporting pathologist reported it as benign breast tissue and just stopped at that. The micro report just stopped at that, benign breast tissue. So surgeon took it as benign and patient was reassured. The mass was increasing in size, so patient came back. And this time the same surgeon decided to perform the excision biopsy. That report was fat necrosis. Now this fat necrosis was actually related to the previous true cut biopsy, which had given rise to fat necrosis. So this was related to that, and this was not actually accounting for the mass lesion which she initially presented with. So again, this time the patient was reassured. 8 months later, she came back with palpable axillary lymph nodes. And the final diagnosis was grade 3 invasive duct carcinoma with metastatic lymph nodes. So the first time in the core biopsy, the surgeon missed the lesion. Second time, he excised the previously biopsied area, which was not the lesion. The main lesion was somewhere else. There were a lot of mistakes here. One is the surgeon never gave us the proper history, what type of mass it was, and how suspicious was the lesion. And the pathologist also didn't say in the microsection that there was no discrete mass lesion present. So it should have been, in the UK practice, it should have been called B1. Yeah. Okay, the another type of discordant is that radiologically it is benign, but it is malignant under the microscope. So that's a discordant biopsy. So do we have an explanation? And if we don't have an explanation, think of whether there is a specimen mix-up. Okay, so the key to correct treatment is communication. In the past, there was only communication between surgeon and pathologist. Then we moved on to the radiologist got involved, and 3 surgeons, pathologists, and radiologists were communicating with each other. But now all 4 are communicating with each other because oncologist also needs information from the pathologist as well as from the radiologist if he or she is going to give a neoadjuvant chemotherapy. Okay, So there I stop you.
Dr.
Any
Zillu, sir?
questions?
Yeah, there were two questions. Shalaka, are you going to take the questions?
Yes. Okay. The question is, can LCIS be a precursor lesion of invasive duct carcinoma?
There is an echo.
Yes.
Yes.
Yes,
Sorry.
LCIS. Sorry. Yeah, you can
Please
hear
go
me
ahead.
now?
Please go ahead.
Yeah. LCIS is both a marker as well as precursor lesion, and it's a non-obligate precursor lesion. So not all LCIS will lead to invasive cancer. Most often, yes, it will lead to invasive lobular cancer, but it can give rise to invasive ductal cancer as well. So just like DCIS, it is also a non-obligate precursor, but the incidence of CIS going into invasive cancer is lower than in DCIS. But it can be both, either ductal or lobular, more commonly lobular.
Thank you, madam. The next question is, how to histologically differentiate flat epithelial atypia, UDH, ADH, and low-grade DCIS?
Okay, I wasn't sure whether you all see flat epithelial atypia there, because it's usually detected in the screening program because of microcalcifications. Again, you can say flat epithelial. Okay, the flat epithelial atypia, ADH, and low-grade DCIS, it's a continuous spectrum. So the flat epithelium, why is it called flat? Because the epithelium is flat. In ADH, you get the architectural atypia, right? You get partial cribriform pattern, or you can get some arches or micropapillae. While in flat epithelial atypia, you are not getting any architectural abnormality. Don't forget the neoplastic cells of flat epithelial atypia, ADH, and low-grade DCIS are identical. So morphologically, immunohistochemically, and genetically, they are identical. It's called flat epithelial atypia because it is flat. So when you start seeing architectural abnormalities, so if you start seeing some micropapillae or partial cribriform pattern or arches, you call it ADH. And ADH versus low-grade DCIs, currently, at the moment, we have 2 millimeter cutoff. Now, we all know currently we are over-diagnosing and over-treating low-grade DCIs. That we all know. In fact, there was a consensus meeting, I think 2003 or something, among all international breast experts, that we should maybe change the threshold to 4 millimeter because we are over-treating low-grade DCIs. But unfortunately, they couldn't come to any consensus. Some said 2.5, some said 3, some said maybe 2 millimeter. So we are stuck at 2 millimeter cutoff. But in a core biopsy, I would say that when you are struggling between ADH and low-grade DCIs, go towards low-grade, go towards ADH. Don't over-call it low-grade DCIs when you are struggling, okay? So there is no way you will differentiate ADH from low-grade DCIs either morphologically or immunohistochemically. From UDH, you will be able to, because UDH will have both epithelial cells which are benign. So if you do your CK516, it will be positive. While in flat epithelial atypia, ADH, and low-grade DCIs, CK56 will be negative. Myoepithelial layer will be present in all these conditions. Am I clear?
Yes, madam.
Yeah.
And there's one more question. What is the significance of reporting DCIS components in an invasive ductal carcinoma
See,
in relation to patient treatment?
Device. I
Shalaka,
think you
should
are
I
using two
answer your
devices.
question?
There are echoes.
Shalaka, you mute your mic. I read out the question.
Yeah.
So, ma'am, the question was, what is the significance of reporting DCIS component in invasive ductal carcinoma?
Yeah. Again, if you get a needle core biopsy and for invasive cancer, you are seeing invasive cancer. If you are seeing a lot of DCIs outside the invasive cancer, it's worth reporting because this patient may have a lot of DCIs around the invasive cancer. So the surgeon and the radiologist maybe check with the mammogram and see whether there is a lot of DCIs outside the main invasive cancer. Then patient may need wider excision to get clear margins. So that way it is helpful because sometimes earlier our surgeons used to say, can you tell us how much DCIs is there in the needle core biopsy? So whether it is associated with extensive DCIs or not, that's what they want to know so that they can plan their treatment accordingly. And particularly if it is non-calcified DCIs, because calcified DCIs, they will be able to see it on mammogram. But if it's non-calcified DCIs, they may not be able to see it. And it's worth reporting it just to let them know that you may not get clear margins first time because there is a lot of DCIs outside the tumor.
I think that's all for the questions, ma'am.
Okay.
We can move to slide seminar.
Okay. So okay, so this is the first case. Okay, do I choose somebody to describe it? The first case is 40-year-old woman presented with a 20-millimeter breast lump, which on radiology was well circumscribed, solid mass lesion, indeterminate nature, favor benign. So my rate category was R3. Shraddha, would you like to describe this?
Yes, ma'am. Ma'am, in this section, study shows a breast parenchyma showing one focus of duct, which is dilated, periductal inflammation. Stroma shows dense stenosis. Also shown a foci of ducts with eosinophilic anemia.
There is still echo. Can these students mute themselves? We will unmute you.
Okay, Shraddha, you want to continue? Remember the history. What is the history given? It was a well circumscribed, solid mass lesion. So go under low power first and tell me what you are seeing under low power. As I said, how do you approach a needed core biopsy? So first thing is that, have you got the targeted lesion in the biopsy? So can you see that is there an interface?
Dr. Shraddha?
Dr. Shraddha, can you unmute?
Yes, ma'am. Am I audible?
Yeah. Yeah, I can hear you. Yeah. So it was done for a well circumscribed mass lesion, solid mass lesion. So first thing, you put it under your low power and see whether you have got a well circumscribed mass lesion or not. So is there a well circumscribed mass lesion? This looks quite solid here. There is no cystic lesion, so obviously it is a solid mass lesion. So now, do you see the interface? Okay, continue, Shraddha.
So in this region, one duct which is dilated,
Yeah.
and periductal region is having an inflammatory reaction.
Varsha ma'am,
Yeah.
are you also hearing the echoes?
No, for me it's quite clear.
Okay, because for rest of us there is a lot of echo.
Okay, for me it's should I mute? I won't be able to talk. Yeah.
Can you mute for
For me there is no echo at all.
Can you mute for a second? You can check it.
Yeah, I will. See, where's the mute one? No.
So, can any student, Shraddha, can you speak now?
Yes, sir.
Now it's clear, ma'am. There is no echo right now.
Yes, sir. There is no echo.
Can you unmute, ma'am, please, Varsha ma'am?
Yeah. Can you hear me now? Yeah.
Yes, ma'am.
Okay. So Shraddha, you are describing it now. As I said, describe first under low power. What are you seeing? Are you seeing a definite mass lesion?
Yes, ma'am. There is
Mass lesion, yeah. Okay.
there is
Varsha, ma'am,
a
sorry to interrupt.
Yeah.
Is by any chance you are using two devices?
No, I'm using only one device.
Okay, we are still trying to figure out the source of echo.
I'm using only one device, so.
Okay.
Something has happened. So we are hearing echoes except for you, ma'am.
Let me.
Right. Did you have an echo in the beginning of the talk or just now?
No. Just now. It has just started.
Oh, it's just started. Because then I don't have another device here, so.
Madam, what you can do is when the rest of them are speaking, I
Now,
think
now
you
it's
can
fine.
mute.
myself.
Yeah.
Now,
I
now
will
it's
write.
fine. Now it's fine. I think.
Yes,
There's no echo.
Yes. Now
But
there
I'm
is no
not
echo.
muted. But I'm not muted, so I don't know why.
Now it's fine. Some technical glitch must be there. So now it's fine. Only. I think it's fine.
I didn't hear. Okay.
Okay.
Shraddha, please carry on. Yeah.
yes, ma'am. Yes, sir. Ma'am,
I can't hear Shraddha.
ma'am, there is one duct which we can see, which is dilated.
Yeah.
And, there is periductal some inflammatory reaction we can see.
Yeah. Do you have any idea where what it is? Okay, shall I try? Okay, Lakshmi, do you want to describe? Is Lakshmi there?
Yeah, Lakshmi, please unmute and speak.
Yes, ma'am. Ma'am, in this section of bone mineral biopsy, there
Yeah.
is adenotic foci
Yeah.
and
Sorry to
areas
interrupt.
of fibrosis.
Again, we are hearing echoes.
I think it's from other side because
Not sure
don't have any.
where it's coming. But now again,
Yes,
it's
sir.
fine. It's fine now. And Lakshmi, can you speak now?
Adenotic foci are seen in areas of fibrosis, and around ducts, there is inflammation. The inflammation was not clear, ma'am, whether it is mixed inflammatory cell infiltrate or there is single cell proliferation around the ducts. Or,
Sorry to interrupt. Is everyone hearing the same?
Yes, sir.
Echo?
There is an echo.
Yes. So I don't know where the
Everyone,
issue is,
please mute yourself.
except for the one who is speaking. Lakshmi, are you there?
Yeah, Lakshmi, go ahead.
and one of the ducts shows mixed soil change, and there is partial absence of epithelium lining in one of the ducts. So one of my is fibrocystic change.
Yeah.
And
Okay.
periductal mastitis.
Yeah.
Because the cells around the ducts are not very clear if there's proliferation or there is inflammatory cell infiltrate around the ducts. But adenosis is quite prominent. Adenotic foci are quite prominent in this biopsy.
Good.
These fibrocystic change.
Yeah. Good description. So now if you have to give a diagnosis, what would you write your diagnosis is? Because the further management is going to depend on the diagnosis.
It could be diagnosis.
Because whoever has done the biopsy would like to know, did he or she get the lesion in the biopsy? And second, if the lesion is present in the biopsy, what is it? Is it benign or is it something which needs to be excised?
Ma'am, it is benign
lesion. Questions we need to answer in our report. So you have to know a little bit about the management of the patient, what's going to happen based on your diagnosis. So make sure you communicate your diagnosis well to the surgeon and the radiologist. Because after all, it's going to be a triple approach for the management. Yeah? So what would you put your bottom line diagnosis?
Benign lesion with fibrocystic change and periductal mastitis.
Okay. So if you have to use the B category, which I talked about earlier, what would you write? B2 or B3? Or B1 even? Do you think that periductal mastitis or just small amount of fibrocystic disease can give rise to a solid mass lesion. Yeah, so what I'm trying to say is that
solid mass can be palpated in fibrocystic change or mastitis. So,
yeah, fibrocystic disease, yes, can sometimes give rise to, so you can get a mass forming fibrocystic change. Yes, I agree with you. Your description was good and your diagnosis is correct. So it would be B2. But if you look at these areas, does it not look like fibroadenoma? This is very typical fibroadenoma picture. Here we got a little bit of intracanalicular pattern. We got a myxoid stroma. We got like pericanalicular and intracanalicular pattern. The main thing is that we have got an interface, first of all. So what I would, if I were to interpret this biopsy, what I would do first is I've got information saying that it is a solid mass lesion, well circumscribed. So first thing, when I put it under the microscope, have I got the interface? And I have got a nice interface here, right? This is the normal breast tissue here. Yeah, look at this normal lobules. There's a little bit of dilated duct, but that's not the part of the lesion. This is outside the lesion. The lesion starts here and then just goes on further on like this, yeah? So now we have decided that at least I have decided that it's a fibroadenoma because I've got areas of looking like fibroadenoma. I've got a targeted lesion, so I'm happy with that. Now I have to decide, is it benign or malignant? I think it's a fibroadenoma, but there is something going on inside the fibroadenoma. So what is going on in the fibroadenoma? So let's look at it, this area first. 1 second. Yeah. So just going to click over. Yeah. So there is a lot of, it looks very busy, isn't it? The whole lesion looks very busy. Fibroadenoma would have more kind of hypocellular areas. But if you see here, there's a proliferation going on here. There's proliferation going on here. So what sort of proliferation is going on? So let's look at this area. Yeah. So under low power, it's got a nice lobular architecture. So it's lobulocentric proliferation, right? And then there are, you said there are spindly looking cells. So what are those cells likely to be? They're likely to be myoepithelial cells because there is sclerosing adenosis going on here. So these areas are all sclerosing adenosis here. That's why, but the nodular architecture is maintained. And then here again, you got the sclerosing adenosis, but within sclerosing adenosis, you are getting a little bit of epithelial kind of apocrine type, immature apocrine type metaplasia. Yeah. So here you can see that. So there are duct-like structures. And then you can see some spindle cells, which are basically, I showed you earlier example of that sclerosing adenosis. You kind of get the streaming of nuclei, almost looking like invasive lobular carcinoma cells. Again, here, it is, again, you can see the streaming of nuclei, single cells. So this is all basically sclerosing adenosis, which is happening within the fibroadenoma, because that's a normal breast tissue, that's fibroadenoma. So it's all happening within the fibroadenoma. And we are quite happy that there is nothing else going. There's no LCIs, there's no DCIs, there's no invasive cancer. And outside the normal breast tissue, other than showing a little bit of cystic change here, there's nothing much going on over here. So I would report it as complex fibroadenoma with foci of sclerosing adenosis, B2. So this doesn't need to be excised. Happy? So let's just go on to PowerPoint. Okay, so this is what I had the pictures of, but we won't go through those again. So that's the diagnosis. Fibroadenoma, it's sclerosing adenosis. Okay, so that's a quiz question for you. Which of the following is typical feature of sclerosing adenosis? Cellular desmoplastic stroma, lobular architecture, absence of myoepithelial cell layer. Do you have an answer here?
Yes, most of the students thought it was B, while a few students thought it was A.
Yeah. So the most common answer is A, is it?
Most common
popular
answer is B,
answer is B, yeah. So that's correct. So that's what I was trying to say. Whenever you are looking at any lesion, don't jump to high power. Go to low power first. That is where you are going to observe the architecture. Because once in sclerosing adenosis, you go into high power, you are going to make a mistake because it will mimic invasive lobular carcinoma. So if the lobulocentric, if it is a lobulocentric proliferation, then it is likely to be sclerosing adenosis. So that's the answer, lobular architecture. Cellular desmoplastic stroma will get in invasive carcinoma, absence of myoepithelial cell layer, again in invasive carcinoma, with the exception I told you earlier, which is microglandular adenosis. So now I'm just going to show you some interactive cases and tell me what you think, and then we can discuss. So this was an R3 well-defined solid mass. Okay, again, it is well-defined, solid mass, probably benign. And you can see there is definite mass lesion because that's the interface. So that's normal breast tissue, normal tissue here, and this is the mass lesion. So this is the lowest power I'm showing you first. So screen under low power, little higher power, high power. What is your diagnosis? Benign or is it lobular carcinoma?
Ma'am, the students are answering in chat box.
Yeah. But I can't see what's the most popular answer though.
Yeah, I'll tell you. Just wait for a few seconds.
Yeah, I can see most of them. Yeah.
So most of the students
diagnosis is benign, isn't it?
Benign. Yes.
Perfect. So that's benign and it is sclerosing adenosis. But you can imagine if you look at only this area, it will look like invasive lobular carcinoma. So main thing is to observe this lobulocentric proliferation. See the nodular architecture. So this is not actually a fibroadenoma. This was a nodule of sclerosing adenosis, which was forming a mass lesion. Okay, so this is basically sclerosing adenosis, nodule of sclerosing adenosis. So does now my histological diagnosis go? So I have made a diagnosis of nodular sclerosing adenosis. So does that diagnosis correlate with radiological abnormality? Yes, it will correlate with abnormality. So if it's but if you had made a diagnosis of invasive lobular carcinoma, it would not have, because invasive lobular carcinoma will never present as a, never say never, but very rarely present as a solid, as a round, well-demarcated mass. So if you diagnose invasive lobular carcinoma in a rounded mass lesion, think twice, thrice, multiple times before you give that diagnosis. So this was sclerosing, and you can see P63 stain highlights the myoepithelial cells. So this was a nodule of sclerosing adenosis, B2, no need to do anything more. Do not excise it. There's no need to excise it, unless, of course, the patient wants it out. So nodular sclerosing adenosis is a lobular carcinoma mimic. Second case, another R3 well-defined solid mass. And here was the interface, that there's fatty tissue here, which can just fallen off here. So it looks like a fibroadenoma again. And then there is something going on here, which I will show you. Again, looks like kind of nodule of kind of sclerosing adenosis, lobulocentric proliferation. But in the same core biopsy now, so we know this is sclerosing adenosis, but there's something going on here. So let's look at that area. Now here we have these cells lining up, linear fashion. So it's in the same core, okay? It is a fibroadenoma, I've told you, but within fibroadenoma, something is going on. First, I showed you was sclerosing adenosis, but then there is something else going on here. And what is your diagnosis now? On this focus here.
It seems the students have equal vote for benign and lobular carcinoma.
Yes, which was I had expected. In fact, this particular case was reported by another pathologist as invasive lobular carcinoma. And you can see why it was reported as invasive lobular carcinoma. Looks like that. But you have to see the entire lesion properly. If you see, if you see the lesion here, the whole lesion is a fibroadenoma. We have got some sclerosing adenosis going on here. We've got some sclerosing adenosis going on here, some here as well. So before you make a diagnosis of invasive lobular carcinoma within a fibroadenoma, make sure that it is not just part of the same spectrum, that it is just sclerosing adenosis, which is mimicking lobular carcinoma. So if you are really seriously considering invasive lobular carcinoma in this focus, when there is already so much sclerosing adenosis going on in the background, then do a P63 stain if you are really stuck now. So, and this the P63 stain in the same area. We have got plenty of myoepithelial cells. Okay, so this is not an invasive lobular carcinoma within fibroadenoma. It is sclerosing adenosis within fibroadenoma. And you can see the cells look almost similar. The epithelial cells look similar in that first focus and the second one. So this is not invasive lobular carcinoma. This is a complex fibroadenoma with sclerosing adenosis within it. So those who got it, got it right. Next case, mass lesion, needle core biopsy. We have a mass lesion here. Again, you can see there is an interface here, and we can see there is a definite mass lesion, and there is something going on inside the mass lesion. Okay, so you can look at that. There's a background fibromyxoid stroma there, and then there is some proliferation going on here. I can tell you that the mass lesion had an appearance of fibroadenoma, but within which there was a lot of proliferation going on. So what is it? Is it fibroadenoma with sclerosing adenosis, or is it lobular carcinoma?
This time, most of the students thought it is option A. Option A.
Okay, so this time we thought it is hyperplasia with sclerosing adenosis. So let's go back to this case again. Okay, so I'm saying, yeah, there is a fibroadenoma. It's got a fibroadenoma type architecture, but whatever it is, it's a mass lesion within which we have got a targeted lesion. We are happy we got a targeted lesion because there is an interface there. So within a mass lesion, we are getting a lot of proliferation, right? Now there is some proliferation within all these ducts and lobules, and there is something going on outside the ducts and between the ducts and lobules. So let's just look at it under higher power magnification. So these lobules are expanded. These ducts are filled with some kind of abnormal proliferation, and these are just inflammatory cells. And then there's something going on here. Yeah. Is this usual duct hyperplasia, or is it DCIS, or is it LCIS? So we'll first take this component, and then we'll take the other component. So what's going on over here? Is this usual duct hyperplasia, or is it something else? If you look at the cells, they are very monomorphic, right? It doesn't have any ductal lumina, any central luminal spaces, which you typically get in DCIS, which we don't have. We have some intracytoplasmic lumina. Let me see whether I have a higher power. No, I don't have. We have some intracytoplasmic lumina. And then there was so this is actually an LCIS, classical LCIS, not pleomorphic LCIS. This is classical LCIS. These are the typical features of classical LCIS. So when you see classical LCIS, then you have to see now what's going on here. What are all these cells here? They are single cells, right? There are some lining up there, right? So this is LCIS. Are you all convinced that it is LCIS? If you are in doubt, you can do CK56, which would be negative. And if you want to differentiate it from DCIS, you can do E-Cardiorin stain. But this, by morphology, this is LCIS morphology. This is not DCIS morphology. There are discohesive cells. There are no ductal luminal spaces. There are intracytoplasmic vacuoles. So this is LCIS. And now, when you have LCIS, and then we are getting these single cells, obviously you have to think of invasive lobular carcinoma because they are they're keeping a company of LCIS, right? So this is actually invasive lobular carcinoma within a fibroadenoma. And you can see these cells are A1, A3 positive. And if you see the P63 stain, those cells, those areas here, we don't have myoepithelial cells. You have myoepithelial cells around LCIS, but not around the invasive foci. So this was actually an invasive lobular carcinoma within a fibroadenoma. So yes, it was done for a mass lesion, which was actually fibroadenoma, but within fibroadenoma, you can say incidentally, because obviously radiologists thought it was R2 or R3. But this patient actually had a lot of invasive lobular carcinoma outside the fibroadenoma. So this invasive lobular carcinoma was just actually coming from outside, and then there was LCIS arising within a fibroadenoma. So this is a very complex fibroadenoma where you're getting invasive cancer. Okay, any questions on this? So this is what sclerosing adenosis looks like, and this is what lobular carcinoma looks like. Obviously, these are very subtle points, but the nuclei are enlarged. It's keeping company of LCIS, and if you do P63 stain, it will be negative in lobular carcinoma. Any questions before we move on to the other next case? Or maybe we'll take questions at the end.
Yes.
Yes. Yeah. So this is another R3 well-defined solid mass. Again, we have interface. There is a solid mass here, which look like a fibroadenoma in other core, but and then there is some proliferation going on here. Yeah. So let's look at this proliferation. There's micropapillary proliferation in fibroadenoma. Yeah. So is this micropapillary hyperplasia, or is it micropapillary DCIS?
So, madam, there are mostly A's and a few B.
Okay, so the A is the correct answer. I think I did show you this picture in my intro talk. So it is micropapillary hyperplasia. Why am I calling it hyperplasia and not DCIS? Because of the papillae. Look at the papillae. They are kind of pointed papillae. They are not bulbous papillae. So broad base, but the pinched out papillae. So this is micropapillary hyperplasia, and this is micropapillary low-grade DCIS. Yeah, you got the bulbous papillae over here. So this is fibroadenoma with micropapillary hyperplasia, B2, no need to do anything more. In the previous case, obviously, where there was invasive lobular carcinoma, it had to come out. So it was B5B in the previous case. Yes, the next one, R3 well-defined solid mass. You can see that there is a fibroadenoma here, which is no problem. And then there is something going on within fibroadenoma.
Madam, mostly people have answered as B. DCIS.
Perfect. Yes, it is DCIS. Yeah, it's a fibroadenoma with DCIS. So you can, do I have, yeah. Sorry. Yeah. It keeps jumping. Yeah. So we have a cribriform the kind of architecture. So here your differential diagnosis would have been whether it is usual duct hyperplasia or is it low-grade DCIS. And you can see the cribriform spaces have punched out spaces, monomorphic nuclei, and rigid bars rather than kind of tapering bars. So this was fibroadenoma with DCIS within it. And again, this patient, so this would be B5A. There was no invasive cancer. So this diagnosis would have been B5A, right? Obviously, patient needed, this needed to be excised. When it was excised, there was a lot of DCIS outside the fibroadenoma, and she needed even wider excision after that. So now, when after making the diagnosis, I said you always have to ask yourself a question: does histological diagnosis correlate with radiological abnormality? When it is concordant, everybody is happy. Okay, if it is all benign, patient can be discharged. What happens when there is R2, R3, B2 concordant discharge, right? Now, what happens when it is R2, R3, like I showed you the two cases? The diagnosis is B5, so it is a discordant diagnosis. So is there any explanation, or if there is no explanation, then rule out any specimen mix-up. And this was our two cases where it was a discordant diagnosis, right? Because we call this B5A and we call this B5B. But we can explain this diagnosis, right? That it is, yes, the mass lesion which they biopsied is there, is a fibroadenoma, but within fibroadenoma, we have found DCIS and invasive lobular carcinoma. So in a way, it is discordant, but we can explain the findings. So we can accept this as diagnosis, right? So I think that's maybe, okay, two more maybe interactive cases. This was another mass lesion, which was core biopsied. It was a well-defined mass lesion, well-demarcated mass lesion. And you can see the mass lesion. There was an interface somewhere here. So what's the diagnosis? I think we can go a little quicker now because we have 4 more cases. Sorry, I should have shown you this slide. Is it benign or malignant? Yeah. Right. So what's the popular diagnosis?
So most of the students thought it is B mucinous carcinoma.
Okay. Right. I will come to that now. So actually, this was a fibroadenoma with a very prominent myxoid stroma. And yes, mucinous carcinoma is a mimic. But so what are the differences? Why is it not a mucinous carcinoma? You have to look at the ductal structures, right? So what are the ductal structures like in mucinous carcinoma? They are more wide, they are open ductal spaces, or you can get micropapillary architecture, but they will have only the epithelium. They will not be in the myoepithelial layer. But you really don't have to do immunostains for that because it will look quite different. So mucinous carcinoma, yes, it can be solid mass lesion, which can be well circumscribed mass lesion. If you do CK5-6 IHC, it will be negative in mucinous carcinoma because there is no myoepithelial layer, and even the ductal epithelium will be negative because it's malignant. And if you do ERPR, there will be diffuse positivity in mucinous carcinoma, while patchy positivity in fibroadenoma. The main thing on morphology, you have to look at those ductal structures. Do they look benign or do they look malignant? Because if you have seen, these are compressed ductal structures which are lined by 2-layered epithelium. So this is actually a fibroadenoma with a very prominent myxoid stroma. And I think even this particular case was called by another pathologist as mucinous carcinoma. But this is just a fibroadenoma with prominent myxoid stroma. B2, no need to do anything more. And this is the last interactive case for case 1. 23-year-old well-defined mass. What's the diagnosis?
The popular answer is A, benign.
Yeah. Yeah, that's right. It looks very cellular, but if I told you this patient was breastfeeding, yeah, you can see very vacuolated cytoplasm everywhere. So this was a benign lactating adenoma B2, nothing more to be done. Okay, I think this is the last slide for this. So now let's move on to case 2.
Ma'am, one kind request for you.
Yeah.
When the students are describing, could you
Yeah.
please mute yourself so that because we are hearing the echo still, you are not the larger audience.
Sure.
So when the student completes description, then you can unmute.
Yeah. Sure.
Thank you.
Yeah. So this is case number 2, which is 28-year-old woman presented with a 25-millimeter breast lump, radiology well circumscribed solid mass lesion, indeterminate nature, BI-RADS category R3.
Yes, anyone, any student?
Okay, I can maybe Abhirami. Yeah.
Am I audible, ma'am?
Yes, you are.
Ma'am, this section shows a single linear core of a breast tissue on the low power, showing both mesenchymal and the epithelial components. Moving on to the higher power, it shows a moderate increase in the cellularity of the stroma with pericanalicular pattern. And also intracanalicular pattern noted here. With increase in stromal cellularity and epithelial hyperplasia. And the cellularity looks more or less uniform.
Okay, so what's the diagnosis? What would you call this?
Ma'am, I will go for a benign fibroepithelial lesion, favoring more towards a cellular fibroadenoma.
Good. So if you have to put B category, you would call it B2, right?
Yes, ma'am.
Benign. Yeah. Good. Very good. Good description. Good observation. So just to go systematically. So we have got a solid mass here, so we really don't have to look for the interface, but there was an interface. So we are happy that we got a mass lesion here, which is a solid mass lesion. It doesn't have the typical fibroadenoma type architecture. Almost they look like normal breast lobules here. And then there is a lot of, they are widely separated by, as you described, kind of cellular looking stroma. Yeah. So we don't have any mixed stroma. We don't have very prominent intracanalicular or pericanalicular pattern. And then, so this, what it looks like, yeah, maybe there is a little bit of hyperplasia, but not much. It's almost like normal breast lobules here. So now the main question is, what is this stroma here, right? And it looks cellular. And let's go high power. So you call it cellular fibroadenoma, it's completely fine. Because call it benign. As long as you call it benign and didn't call it a phyllodes tumor. That's the main thing. What does this, what are these cells, what do they remind you of? What these are kind of fascicles of spindle cells running longitudinally and some cut transversely here. Can you maybe go under high power? What do they look like? This little bit of cigar-shaped nuclei. Here, what are these bundles of cells here, spindle cells? They look like smooth muscle bundles, right?
Yes.
Yeah? So these are kind of smooth muscle bundles cut transversely. These are longitudinally. So you're getting kind of fascicles of smooth muscle bundles. There is no nuclear atypia. There is no mitotic activity. So we'll go now to the PowerPoint presentation. So let me switch to PowerPoint. Page 2. The diagnosis anyway. Okay. So we are going to just go through this. So case 2. Yes, I showed you some all these fascicles of, looks like kind of smooth muscle bundles, right? So the diagnosis, Desmin is positive, confirming that these are smooth muscle bundles. And then it was excised. It was excised because on the core biopsy, the reporting pathologists had reported that phyllodes tumor cannot be excluded. So it was reported as B3. When we raise the possibility of phyllodes tumor, something which needs to come out, we put it as B3 category. So that's why it was excised. And it was a well-circumscribed mass lesion. And see, the Desmin is strongly positive again. So this is a myeloid hematoma. It is a variant kind of, it's not exactly a fibroadenoma, but as long as you called it benign, it is fine. But it is because there is so much smooth muscle, there are so many smooth muscle bundles in it, it is called myeloid hematoma. So hematomatous lesion is basically a benign breastish type looking lesion, which is hyperplastic. It may have fat in it, it may have smooth muscle in it. So here we can go through it. It's a really benign lesion. It's like fibroadenoma, it is well circumscribed. When this trauma within the lesion is predominantly smooth muscle, we call it myeloid hematoma. We don't see prominent pericanalicula obstructive patches. Usually what we see is normal lobules or ducts in varying proportion. And as I said, it can mimic cellular fibroadenoma or phyllodes tumor. As I said, cellular fibroadenoma, if you call it to differentiate, is not critical because both are benign and they don't need to be excised. But if you call it benign phyllodes tumor, yes, it requires complete excision with margin. And I already explained to you how benign phyllodes tumor looks like. We really don't have any of these features. We don't have cleft-like spaces. We don't have leaf-like projections. Other than cellular stroma, there is really nothing which would suggest benign phyllodes tumor. So this was a benign hematoma. Here is a question. I think I'm just going to go through it now quickly because we have three more cases. Which feature is typical of hematoma in a needle biopsy? So I just talked about it, so you know which it is, right? The answer would be well circumscribed interface. There won't be any infiltrative architecture or perineural invasion. So I'll just go back to case 3 now. Okay, this is case 3. Case 3 history is 55-year-old female, screening mammogram, architectural distortion suspicious for malignancy R4. Amita, do you want to describe this?
Yes, madam.
Yeah.
Picture showing on linear core needle biopsy of breast. There is proliferation of small round glands that are arranged haphazardly within adipocyte and fibrous tissue. The glands are open and contain bright eosinophilic luminal secretion. There is no myoepithelial layer is seen.
So diagnosis?
Microgranular adenosis.
Okay. So it was R4, yeah? And we are calling it benign,
yes.
Microglandular adenosis. What would you tell or how will you communicate to the surgeon as far as the further management is concerned? What will you kind of, see in the UK we write category B2, B3, B4. So when I write B3, the surgeon knows that it needs to be excised. When I say B2, surgeon knows that there's nothing more need to be done. So are you going to say anything to your surgeon? How are you going to communicate with your surgeon? Surgeon will say, okay, I don't know what is microglandular adenosis. What do I do next? What are you going to tell him?
We should do IC. We should do IC.
That you are going to do, yes, and to confirm the diagnosis, right?
Yes.
Yeah. So once you confirm, we will go through that. And once you say that you are happy that it's not invasive cancer, but microglandular adenosis, which you confirm by what ISC will you do?
S100 and P63.
How will that help? Tell me.
S100 will be diffusely and strongly positive.
Yeah. What type of positivity do you expect with S100? What does it normally stain? S100? Cytoplasm, membrane, nucleus?
Nucleus and cytoplasm.
Good. Yeah. You have to have nuclear staining as well. Just cytoplasmic staining may not be enough. Because sometimes you do get false positive, just cytoplasmic staining, but you don't have nuclear staining. Yeah. So S100, and you said P63, you said, right? How will that help?
Yes. P63 will be negative.
So why is this not invasive duct?
And to exclude invasive carcinoma, we should use ERPR and HER2.
Okay, and how will that help?
ER pair and HER2 will
So what is your difference? Let's first come to what is your differential diagnosis here?
tubular
Before you
carcinoma.
do tubular carcinoma, right? So for tubular carcinoma, you said you will do S100, ER-PR, P63, HER2. Now tell me how each stain will differentiate it from microglandular adenosis. Let's take the first stain. S100 you said will be positive in microglandular adenosis. And what in invasive cancer? Is it positive, negative? S100.
S100 negative.
Negative. Usually it's negative. There are very few invasive duct cancers of the breast can be S100 positive, but generally, typically it is negative. So don't rely just on S100. What are the stain?
Yes.
ER?
ER-PR.
Negative or positive?
If it is tubular carcinoma, then it will be positive.
Yeah. And microglandular adenosis will be negative.
Yes.
P63 will be negative in both, right?
Yes, madam.
Is there any other stain you can do? Because I know tubular carcinomas have to be 100% kind of ER positive. But trust me, I have seen tubular carcinoma which went ER negative. Very, very rare, but it was negative. So, and HER2 will be negative anyway in tubular carcinoma. You wouldn't expect it to be positive. And HER2 may be negative even in
collagen 4 and
so in fact, it is
for the
negative in
basement membrane.
Will you do basement? Yeah, I have never done basement membrane stain because I find it extremely difficult to interpret. Is there any other? Tubular carcinoma is an epithelial tumor. Actually, microglandular adenosis is also epithelial, but there is another. You can do EMA. Yeah, epithelial membrane antigen. Tubular carcinomas are positive, microglandular adenosis is negative. So you do need a panel of, if your EMA is negative and your S100 is positive, it will kind of support your, and your ER negative, support your diagnosis of microglandular adenosis. Because microglandular adenosis is triple negative, isn't it? Okay, so what can you tell me about microglandular adenosis? Or should we just go down to the PowerPoint presentation? So microglandular adenosis, this would be case number 3. Okay, so we described all this microglandular adenosis. So diagnosis correct and description was perfect. So yeah, it is microglandular adenosis. So I will show you it was ER completely negative, P63 was negative, and S100, there were positive nuclei as well as cytoplasmic positivity. So this is the typical immunoprofile of microglandular adenosis. So what is microglandular adenosis? It is a benign proliferative glandular lesion, but it can mimic invasive carcinoma both radiologically, under the microscope, and clinically. It can present as either mass lesion or architectural distortion or calcification because those secretions undergo calcifications. They get calcified and present as calcifications. And it is characterized by haphazard disordered proliferation of small round glands devoid of myoepithelial layer, as you say. Nuclei are small and uniform. ATPR can be present and it can be associated with other benign lesions, but most importantly, it can be associated with invasive carcinoma, particularly high-grade invasive metaplastic type carcinoma or actinic cell carcinoma. So if I report microglandular adenosis, I call it B3. One is that it needs to come out because it may be associated with high-grade carcinoma. So you really want to examine the entire lesion, and it can progress to high-grade carcinoma as well. So you need to excise it completely. So it's typically triple negative, myoepithelial markers are negative, S100 positive, and EMA negative. Molecular changes present at P53 and PIK3CA mutations are present. And these are the mutations which you get in high-grade invasive duct carcinoma. And this I already said that because it is may be associated with this or can progress to high-grade carcinoma, some people do think that it is a non-obligate precursor lesion to triple negative cancers or actinic cell carcinomas. So if I show you the pathway here, the TP53 and PIK3 pathway, so we have microglandular adenosis here, which is low-grade triple negative breast neoplasia family. There can be atypical microglandular adenosis, and it can progress to actinic cell carcinoma, which is a salivary gland type carcinoma. And that can then progress to high-grade triple negative breast carcinoma. And that's why these lesions need to be excised completely if you diagnose it on core biopsy. Right, so it requires complete excision. Differential diagnosis, as you said, the tubular carcinoma is a differential diagnosis. Both have infiltrative pattern under the microscope. Both have single layered glands. There's no myoepithelial layer. So the IHC is negative for myoepithelial cells. But this is very typical. Intraluminal eosinophilic material is very typical of microglandular adenosis. We rarely see that in tubular carcinoma. And the architecture of the glandular architecture is rounded, while the tubular carcinoma has angulated glands. So if you compare microglandular adenosis with tubular carcinoma, look at the tubular carcinoma glands. They are kind of angulated. So they are not rounded glands as you see in microglandular adenosis. There are no this thick, rounded eosinophilic secretions within tubular carcinoma. So these two features are pretty diagnostic of to differentiate tubular carcinoma from microglandular adenosis. And then if you are stuck, obviously you can do immunohistochemistry. And then EMA negative, I have
one question, madam.
Yes, go ahead. Go ahead. Sorry, go ahead with your question.
If we don't have immunohistochemistry facility,
yeah,
then
yeah, but see, if you think that it is an invasive cancer, because that's what you are worried about, that if you think it's invasive cancer, but you will obviously be doing ER because all invasive cancers need ER. So if I'm coming to that slide, next one. So whenever you see anything which looks like low-grade invasive ductal carcinoma or tubular carcinoma, but it is ER and PR negative, think of other things. Because very, very rarely, I know I had one case or two cases maybe which were ER negative, but almost always otherwise, tubular carcinomas are strongly ER positive. So when you get ER, PR negative, low-grade invasive duct carcinoma, consider other possibilities. Microglandular adenosis is one of them. Salivary gland-like tumors is other. And the metastatic neuroendocrine carcinoma can mimic invasive duct carcinoma, well-differentiated neuroendocrine carcinoma. But once you see that is ER negative, yes, you have to think of all these possibilities. So I don't know whether that answers your question about if you don't have immuno facilities. So if you don't have even ER, PR facility, then obviously you have to send it somewhere where you can do some stains if you're seriously considering invasive duct carcinoma versus microglandular adenosis. But as I said, some morphological features are very typical of microglandular adenosis, are those secretions and the rounded glands, while angulated glands for tubular carcinoma. Does that answer your question?
thank you, madam.
Okay.
So the popular option is this time, ma'am.
C, right? Yeah, the intraluminal material is present in microglandular adenosis. There is no myoepithelial layer, and it is not considered malignant. It is considered benign, and some consider that it may be a non-obligate precursor lesion, but definitely not malignant if you don't have any associated atypical features. So I will go on to the next case. So this is now case number 4, which is a 38-year-old woman presented with a 25mm breast lump. Radiology is stellate, solid mass, lesion suspicious for malignancy, R4. Is Partha there? Partha can describe this?
Yes, ma'am. This biopsy, core-needle biopsy shows single core with interface, ma'am. Cannot see much of the glands here. Going to high power. Going to higher power, ma'am. We can see the round to oval cells, ma'am. We can see large round to oval cells with eosinophilic cytoplasm, which is also granular, and nucleus is round to oval, ma'am. The large round to oval cells with eosinophilic cytoplasm. Hello, ma'am. Am I audible, ma'am?
Yes, yes. What's your interpretation, final interpretation?
It looks like granular cell tumor, sir.
Varsha madam? Hello madam, are you there?
I see Dr. Barsha is muted, so she needs to be unmuted.
Some connection issues there with Varsha ma'am.
Sir, would you like to comment, sir?
I'm calling ma'am. Meanwhile, Zelu sir can comment, share his comments.
Okay. Thank you for my consideration. I shall discuss about the previous part of the talk that I think Dr. Barsha is back here. Oh. So by this talk, I think that radiological correlation is very essential for us. And we have seen that biopsy categorization in case of core needle biopsy is very essential because small biopsy and large tissue histopathology is a bit different. In case of small biopsy, we have to see the interface and we have to ensure that whether the tissue is from the mass lesion or not.
Sorry, I had got logged out somehow. I don't know why.
Okay. Okay. Thank you very much.
No problem. So
Varsha madam, please unmute yourself.
can you hear me now?
Yes, madam.
Okay, so we are now on case 4, isn't it? Yeah.
Probably got to share.
Oh, shit. Can you see it? I don't know. It's
No, madam.
because
Okay,
okay, one sec. I'll just share again because I got locked out in between. Okay.
Yes, we can see your screen now.
Yeah.
There is no echo as well.
Oh, that's good.
Hello, ma'am.
So this was the case 4.
Hello.
The diagnosis, I didn't hear the diagnosis, but the description was perfect. That one is that, yeah, it is an infiltrative lesion because you can see the margins are infiltrative, and then there are nests of cells with granular cytoplasm and very round nuclei. So this is just one question before we go on to.
The popular answer is A, mitochondria. There are a few B's and C's.
Okay. Yeah, the answer is actually phagolysosomes, which are ES diastase positive. So in granular, so you know the diagnosis that it's a granular cell tumor, and yeah, you can confirm it. This was a very typical morphology. You didn't have to do the stain, but if you do immunostaining for S100, you can see both nuclear and cytoplasmic positivity. So this confirms the diagnosis of granular cell tumor. And the differential diagnosis will include, because it's an infiltrative type of lesion, you may consider any invasive lobular carcinoma, which can have granular cytoplasm. So one of them would be apocrine carcinoma. Lobular carcinoma can have very granular epithelial looking cytoplasm, and ductal carcinomas. Rarely metastatic melanomas can metastasize to breast, and they can mimic granular cell tumor. But all these entities will have atypia, while the benign granular cell tumors should not have any nuclear atypia. So here again we have, what is it? Okay, we have another which was R4 or R5 lesion, but we are giving it a benign diagnosis. But we do have an explanation for the benign diagnosis, right? Because it's a granular cell tumor. So which are the other R4, R5 lesions which may turn out to be benign on histology under the microscope? So one of them is fat necrosis, sometimes can mimic cancer. Fibromatosis can mimic cancer, and microglandular adenosis, which is for the example of. So all these lesions, there is an explanation for calling them benign. Okay, and granular cell tumor, what would be the treatment? Normally it is excised, though it's a benign lesion, we kind of excise it. So we call it B3 on core biopsy, but it has a benign outcome. So any questions on this before we move on to the last case? So the last, I'm muted again? No, I'm not. No. So the last case is 32-year-old woman with a 30 millimeter subareolar mass. Radiology revealed a relatively well-circumscribed solid mass suspicious for malignancy R4. So who's going to describe this? Lavina or Lakshmi, anybody?
Dr. Ashwini Kumar is also there.
Oh, Ashwini Kumar, okay, yeah. Yeah.
And the stained slide of drift core biopsy shows tumor arranged in the solid cyst trabeculae and cribriform pattern. At low power, we can see multiple irregular areas which are filled with both eosinophilic and mucinous material. Few of the dilated glands are seen in the uppermost core. Going to high power, these cells are medium large size, have abundant eosinophilic granular cytoplasm, single centrally placed round to oval nucleus with vesicular chromatin and conspicuous nucleoli. Focal areas of sclerosarcoma are seen. There is no increased mitosis, necrosis, or hemorrhage. So, my differential hypocrine adenoma. Second differential, typical ductal hyperplasia with fluid hypocrine chain.
Sorry, I didn't hear the first one. What was your first diagnosis?
Hypocrine adenoma.
Hypocrine adenoma, okay. Yeah, so how are you going to sort out? So it was an R4 mass, so suspicious lesion. And you can see it is a cellular lesion.
Yes, ma'am.
And your description was perfect. The nuclei are low grade. There's a lot of this highly nice stroma. It's not exactly a desmoplastic stroma. It's a highly nice stroma. A little bit myxoid maybe here, maybe.
Yes, ma'am.
Yeah. So it is a well circumscribed mass lesion which we saw, and then there's kind of epithelial proliferation is set in a stroma which is mainly hyalinized or myxoid, but not really a desmoplastic stroma. The epithelial proliferation is low grade proliferation, with not much mitotic activity, no nuclear atypia. So the first diagnosis was apocrine adenoma. Would you get apocrine adenoma like this? Did you get all this stroma within the apocrine adenoma? What was the second differential? Atypical hyperplasia.
Yes.
But atypical hyperplasia, would it form a mass lesion? You're seeing a definite mass lesion, isn't it? Atypical duct hyperplasia, unless you are saying that it is a mass lesion within which you have some atypical hyperplasia. That is possible, but atypical duct hyperplasia by itself will not present as a mass lesion. It's usually a microscopic finding. But yes, if it is a mass lesion within which we are seeing atypical hyperplasia or some kind of atypical proliferation, which is very good, which is what it is basically. So now you have to decide what exactly is this mass lesion, which is kind of showing biphasic type of picture. We are getting epithelial proliferation, and then we are getting some kind of stromal proliferation, some kind of different type of stroma we are getting.
Yes, ma'am.
So will you do any stains or anything, or how will you take it further? Suppose you didn't have the stroma, or what would you have called it? I mean, this is very cellular, isn't it?
Yes, ma'am.
I mean, this was initially diagnosed as invasive duct carcinoma. Yeah, I mean, it looks like
Yes.
we are not seeing very rounded lesion here because we don't seem to have good interface, but that is going against the radiology finding that invasive duct carcinoma is very rarely a rounded lesion unless it is a mucinous type of carcinoma. So that is a problem. The second thing is, let me see now, if we go back to the PowerPoint. So are you, I'll go back to the PowerPoint presentation now. Okay. So this is a cellular proliferation which you are seeing, and it is relatively uniform, almost low-grade DCIS type nuclei, isn't it? So it is a relatively uniform population. We have a lot of hyalinized myxoid stroma separating the islands of epithelial proliferation here. So why is this not an invasive duct carcinoma? Just maybe a little bit of apocrine type of invasive duct carcinoma. It was only when the ER came out, which was completely negative. Now, when there, as I said earlier, in a low-grade invasive carcinoma, when the ER is negative, think of something else because it is almost always positive, except in pathology or in science, never say always and never say never. So there are always exceptions, but typically ER should be positive in low-grade invasive. So we went back to the H&E to see what it could be. And then where is this mass? It is a subareolar mass. It has got a fibromyxoid stroma. It seems to have biphasic type pattern. Suppose I told you that this mass was in a parotid gland. What would you call it then? Ashwini, you can answer that question. If I say this is in a parotid gland.
Pleomorphic adenoma.
Pleomorphic adenoma. It exactly looks like pleomorphic. Once you kind of think of it, yes, it looks like pleomorphic adenoma, isn't it? I mean, if I was given this slide, say this is a biopsy from a salivary gland, it is a pleomorphic adenoma. So once the ER came out, then we thought of kind of, yes, it could be pleomorphic adenoma. CK56, they're positive. Again, invasive duct carcinoma, you would expect CK56 to be negative. And I can see this one was, it's 10, sorry. This jumps. Yeah, ER was negative. And P63 was negative. So there are some features in favor of invasive duct carcinoma. One is morphology and P63 because it's negative. You would expect benign lesions to have P63 positivity. But then the pleomorphic adenoma of the breast has a very different immunoprofile. So let's talk about, so this was a pleomorphic adenoma, which usually presents as a subareolar mass. Okay, but this was excised because it needs to be excised. And you can see it is a very well circumscribed mass lesion. And here you have no problem because you have fibromyxoid stroma and it looks just like salivary gland pleomorphic adenoma. So it is a rare breast tumor, but when you get a biopsy which looks like pleomorphic adenoma of the breast, just check whether it was a superficial tumor or whether it was in the breast parenchyma itself. Because if it's a superficial tumor, then it is a mixed skin adnexal tumor, which looks like pleomorphic adenoma, right? And that really doesn't need to be excised. So if it is superficial, it's more likely to be skin tumor rather than the breast tumor. So if it is in the breast parenchyma, then you make a diagnosis of pleomorphic adenoma. Usually it is retroareolar. And the morphological IHC features are typical to salivary gland adenoma. Only thing is that even if it's the benign tumor here, it usually in the breast, the pleomorphic adenoma, it lacks the peripheral myoepithelial layer. It has a lot of myoepithelial cells within the lesion, in the center of the nests, but usually the lack of myoepithelial layer at the periphery. Now, according to WHO, it is a benign, it is called pleomorphic adenoma, and it's a benign tumor. It needs to be excised because there are occasional case reports of metastasis. It's a rare tumor, so we do excise it. It may recur after excision. Malignant transformation has been reported, but it's very rare. What would be your differential diagnosis? Because of the myxoid stroma, it could look like mucinous carcinoma. But the mucinous carcinoma, again, like in fibroadenoma, I told you, they are the neoplastic epithelial cells, duct-like structures which are floating within the proper mucin rather than the myxoid stroma. And if you see the CK56 will be negative, pleomorphic adenoma is positive, negative for ER/PR. P63 may be positive or negative. In my case, it was completely negative. And S100 is positive in pleomorphic adenoma. The other one is, could it be a matrix producing metaplastic invasive carcinoma? Now, most of them, they are high-grade metaplastic carcinoma we are talking about. So they will have high nuclear grade HEPR, mitosis, or necrosis. But could it be a low-grade matrix producing metaplastic carcinoma? I'll come to it just in the next slide. And the other differential diagnosis, because it's a biphasic tumor, adenomyoepithelioma is the other differential diagnosis. So here is the adenomyoepithelioma, which is it was a mass lesion which was biopsied. And you can see there is a proliferation of, this is a spindle cell type of adenomyoepithelioma. So we have a lot of spindle cell proliferation and the glandular structures. Yeah, so this is an adenomyoepithelioma. So it has, what is adenomyoepithelioma? It's a biphasic tumor. It has got multinodular architecture, and you have glandular structures which are lined by epithelial cells, which could be either epithelial cells, an outer layer of myoepithelial cells, which could be either epithelial or spindly. And there is a dual population of cells. So we have CK56 positivity in the inner epithelial cells, P63 positivity in myoepithelial layer. And that's the CK56 in adenomyoepithelioma. And P63 showing all the myoepithelial cells. Adenomyoepithelioma is considered to be tumor of low malignant potential because it can sometimes progress to invasive cancer. So complete excision is recommended. I have put this as a question, but let's not take a vote. We just talk, is it considered benign, uncertain malignant potential, or malignant? WHO, okay, you want to vote, people want to vote for it, you can vote. Can't hear you. So most of the people have gone for benign, isn't it?
Yes, ma'am. Most of the people have voted for benign.
Yeah, it is, as I said, WHO considers it as benign, but you may come across a paper saying that it is of uncertain malignant potential. And some breast experts would like to call this tumor as pleomorphic adenoma-like tumor. And they call it as pleomorphic adenoma-like tumor of low malignant potential. Why do they say that? Because one is that in their study, one case of pleomorphic like adenoma was associated with DCIs. In other 1 or 2 cases, they had areas looking like low-grade adenosquamous carcinoma. And on morphology, because there is no myoepithelial layer at the periphery, that's why they want to call it as, it is actually a carcinoma of maybe low malignant potential. But that is only one group of breast pathologists who have published a paper. But you have to go by WHO, which they said it's a benign tumor. So the experts who think it is low malignant potential, it may be a lower end of a matrix producing low metaplastic breast cancer. Okay, but whatever you want to call it, whether you call it PA-like tumor or pleomorphic adenoma, the management is the same. It's just the excision with a little bit of clear margin. There is no need to do axillary sampling. There is no need to give radiotherapy, and there is no need to give, obviously this is going to be ER negative, so you're not going to give hormonal therapy anyway. So I think that is my last slide. So that finishes all our cases now. Any more questions? So I will stop sharing now. Any questions and comments, anything? And if Dr. Mandar is here, have I answered his question? What, I don't know, he had asked me a question before the slide seminar.
I think Dr. Mandar has logged out.
Okay.
But you may still choose to answer the question.
Yeah.
Any questions from the attendees? Please.
Madam, can you hear me?
Yeah, I can hear you. Yeah.
Madam, in the last case, can we consider a ductal adenoma?
Ductal adenoma, yes, it is a retroareolar mass. And it's a well-circumscribed mass. So your differential diagnosis, at least before looking at the slide, yes, could it be a ductal adenoma? Ductal adenoma is like a variant of intraduct papilloma. And in fact, pleomorphic adenoma is probably arises from intraduct papilloma. So they are all within the same spectrum. But when you, in ductal adenoma, you would not get this mesenchymal component, which you are seeing as hyalinized myxoid stroma. But I think they are all kind of more or less in the same spectrum. Intraduct papilloma, ductal adenoma, pleomorphic adenoma. Pleomorphic adenoma is a biphasic tumor, means you have epithelial and mesenchymal component, while in ductal adenoma, you don't have the component. You have mainly epithelial proliferation. And it will be lined by double-layered epithelium, myepithelium and epithelium. Good question.
Thank you. Thank you.
Madam, there is one question in the chat box.
Yeah.
Can invasive lobular carcinoma
arise purely in a fibroadenoma without an associated malignancy in the outside breast?
Yes, it can. We have seen cases, and when fibroadenoma was excised, there was no invasive cancer outside, so it was limited to the. I suppose it probably comes from the LCIs, because within fibroadenoma you can get LCIs and then you can get invasive cancer. It is very rare, I mean, but you can get it. Yes. More common scenario would be that it's coming from outside and it's just invading the pre-existing benign lesion.
There's one more question. How to differentiate LCIs from solid DCIs morphologically?
Yes, a very good question. I've seen a lot of people, miscalling it papillary DCIs as LCIs. Solid papillary DCIs, it's a mass forming layer. I mean, obviously your differential diagnosis is classical LCIs versus solid papillary DCIs, isn't it? So solid papillary DCIs is a mass forming lesion. It's a well circumscribed mass lesion. The cells are usually plasmacytoid. Same, even in LCIs, the cells are plasmacytoid. But if you look at the cytoplasm of solid papillary carcinoma cells, they look kind of more eosinophilic and granular, and that is because they have got neuroendocrine granules in there. So the solid papillary DCIs will have neuroendocrine granules in it. So if you want to do, you can do either neuroendocrine markers, or rather easier would be to do E-cadherin stain. E-cadherin will be negative in LCIs, and it will be positive in solid papillary DCIs. And also in solid papillary DCIs, you will have that peripheral palisading of the cells, just like in other DCIs. So morphologically, you will be able to differentiate, but if you are in doubt, then do E-cadherin. But I think classical LCIs presenting as a solid mass is a bit rare. Yes, you can get florid LCIs presenting as a mass as a kind of expanded mass lesion, but you will have necrosis in it as well. But if in doubt, you can do E-cadherin. But I've seen a couple of cases where they were called LCIs, but they turned out to be, they were actually solid papillary DCIs. It falls in the neuroendocrine carcinoma spectrum. Any other questions?
Yeah. Do we see myoepithelial lining in all DCIS lesions?
Good, very good question. Most low-grade DCIs will have a myoepithelial layer. High-grade DCIs should have myoepithelial layer and will have myoepithelial layer, but in a given plane, in a given section, you may not see myoepithelial layer in one duct, but if you look for it in the other duct, you will probably see. Because as I said, as the ducts get expanded, the myoepithelial cells get atrophic and you may not see them. So in high-grade and low-grade DCIs, yes, you will see myoepithelial layers. But you know that now this encysted papillary DCIs, in the past we used to call that encysted papillary DCIs. Now we call them encapsulated papillary carcinoma. Why did they change the terminology? Because most of these encysted papillary DCIs, which we used to call in the past, they didn't have a peripheral myoepithelial layer. By multiple myoepithelial markers, we were not able to demonstrate myoepithelial layer. But at the same time, it is very well circumscribed mass lesion. So what now the feeling is that it is an encapsulated low-grade papillary carcinoma. It is a form of invasive carcinoma, but it is an expansile type of invasive carcinoma. And the metastatic rate is very, very low. I mean, there are very few examples of lymph node metastasis with pure encapsulated papillary low-grade carcinoma. If it is high-grade, it is invasive cancer, even if it is well circumscribed. But if it is low-grade, in the UK, we call it encapsulated low-grade papillary carcinoma B5A. Why we call it B5A and B5, not B5B? Because the incidence of axillary lymph node metastasis is so low that it is not worth doing axillary sampling in these cases. But at the same time, some surgeons do go ahead and do with any mass forming DCIs, they would do axillary lymph node, sentinel lymph node. Having said that, just last week I had a case of low-grade encapsulated carcinoma with metastasis in the lymph node, which looked like low-grade encapsulated carcinoma in the lymph node. So that was a true invasive carcinoma. So they are all considered to be expansile type of invasive carcinoma. So not all DCIs, which we used to call DCIs in the past, have myoepithelial layer. Does that answer the question? Any other questions?
No more questions in the chat box.
Okay. Any other comments, questions, suggestions?
Dr. Zilu, do you want to comment on something?
My comment, I really appreciate Dr. Varsha for excellent deliberation and explanation of the cases, and cases are really excellent. And one thing I see that I have also pleomorphic adenoma, and I thought it to be the mucosal-like lesion. with some fluoride hyperplasia. So the case was very critical and needs some experience. I appreciate Dr. Varsha for the excellent cases she has shown us today. Thank you, madam.